All right. Well, good afternoon, folks. Happy New Year. I hope you had a great vacation and you all were got to see some family, or if you were like many of like many of my friends, we were quarantining safely and enjoying still got the chance to enjoy the break and the holiday. Welcome to our first webinar of 2022. Just appreciate all of you for joining us for the last about 2 years doing these. I'm really excited about today's panel because I think it'll be one of the most informational and necessary ones as we deal with our third or fourth iteration of COVID, our changes in COVID. It's good to talk to some experts about this. Talking about tackling COVID in 2019, tackling COVID-19 in 2022. Leading this discussion will be somebody much better in the healthcare space than I am. We have a 40 under 40 winner, Orriel Richardson, who is Ways and Means Health Counsel, and this is her last day as Ways and Means Health Counsel before she transitions. So congratulations on whatever new opportunity, and thank you for your work on the committee, and thank you for your work with us. And without further ado, I'll turn it to Orriel.
Thanks so much, Brandon, and thanks to the entire NMQF team for being so supportive of me during my time on the Hill. It's been transformational, and I'm very proud of the work that we've done on the Ways and Means Committee to advance health equity. I'm extremely excited today to moderate this conversation because I think that particularly among the Black community, this variant has been, if nothing but entertaining and memeville. It's been something that has certainly brought us all back to a realization that we are very much still in the throes of a pandemic. We are very much still in the midst of a life-changing time, and even just a pivotal point in like human civilization. And so Brandon said I'm much more suited to moderate this conversation, but my science degree in undergrad certainly does not position me to be more astute at having this conversation than the two doctors that we're fortunate to be joined by today. First, we have Dr. Akilah Jefferson Shaw. She is an assistant professor of pediatrics at the University of Arkansas for Medical Sciences College of Medicine and Arkansas Children's Hospital. She's also an asthma researcher at Arkansas Children's Research Institute, where her research is primarily focused on asthma, health disparities, and health policy. She received her medical degree from the illustrious Tulane University, and she completed internal medicine residency at the George Washington University Hospital, also completing her allergy and immunology fellowship at the National Institute of Allergy and Infectious Diseases at NIH. She joined UAMS faculty in 2020. She was named one of NMQF's 40 under 40 in 2021 and has immersed herself into issues related to health disparities and ethics during the pandemic. She's engaged through invited lectures, publications, and popular media outlets such as the Huffington Post and NPR. She's a member of the American Academy of Allergy, Asthma, and Immunology, the American College of Allergy, Asthma, and Immunology, and the Academy of Pediatrics, excuse me. We are also joined by Dr. Loren Robinson, and I'm happy to see her again. She was actually one of our witnesses at a very historical hearing about maternal mortality at the Ways and Means Committee. But Dr. Robinson has since transitioned to be the Chief Medical Officer and Vice President for Medical Affairs at CHRISTUS St. Michael Health System in Texarkana, Texas, where she is responsible for hospital quality and safety efforts and physician recruitment. During the COVID-19 response, Dr. Robinson has served as the physician lead and medical technical specialist lead for the hospital's incident command structure. Prior to joining CHRISTUS, she served as Deputy Secretary for Health Promotion and Disease Prevention for the Commonwealth of Pennsylvania. In this role, her focus was on preventive health and wellness programs geared towards improving the well-being of all Pennsylvanians. She completed the Robert Wood Johnson Foundation Clinical Scholars Program at the University of Pennsylvania, where she also served as a fellow in the Leonard Davis Institute of Health Economics and the Penn Institute for Urban Research. More recently, she graduated from the prestigious Presidential Leadership Scholars Program, a national program that brings together leaders from across nonprofit, military, public, and private sector fields to learn leadership lessons firsthand from past presidents. Dr. Robinson received her medical degree from Duke University and completed the Internal Medicine and Pediatrics Residency Program at UNC Chapel Hill in North Carolina. As a practicing internist and pediatrician, she cares for patients of all ages. Originally from Buffalo, New York, Dr. Robinson attended Spelman College in Atlanta, Georgia, where she graduated summa cum laude with a degree in French and currently serves on the Board of Trustees, the college's youngest ever alumni trustee. Please join me in welcoming both of our panelists today. And I think that one of the things that we're going to do as we get started and arrange ourselves is ask the attendees to respond to the poll question. We're just a little curious to see the extent to which COVID and Omicron have affected you personally, and so we'll touch back on that topic a little bit later in the webinar today. But I want to begin by asking in turn Dr. Shah, Dr. Jefferson Shaw, and Dr. Robinson for any opening comments that they'd like to make, just to kind of level set and determine kind of their take on where we are going into the junior year of the COVID-19 pandemic. Dr. Jefferson Shaw, we'll start with you.
Absolutely. First, thank you all for having me here. I'm always excited when I get a call from the NMQF about doing anything at all. So very happy to be here. I guess as far as opening comments go, you mentioned a huge one, which is that we're still in the throes of COVID-19. The pandemic is not over. And I think it's important to remind people of that, to keep each other safe and healthy as much as we can. The other thing I would mention is that we know that certain things work. So vaccines, boosters work. We know masking works. And so really leaning on that when we're trying to figure out how to tackle COVID-19 in 2022. And I'll let Dr. Robinson give her remarks.
Thank you, Dr. Jefferson Shaw, and I echo your sentiments. It's so exciting, and I think really helps to recenter our work to come together like this. And thanks to the NMQF for doing this, to think kind of bigger picture and smaller picture at the same time. I was really excited to see Orriel again, and then really excited that Dr. Jefferson Shaw is right up the road. I told my husband, I was like, oh, she's right up the street. She's in Little Rock. We can get her. And then I saw that you're a pediatric allergist and immunologist. I was like, I don't think I can get you to Texarkana, but maybe we can get you and Dr. Shah to come visit us in Texarkana, because I think there's just, we all have so many lessons to continue to learn from COVID-19. And I think that's the exciting part of this. Those who know me know I'm an eternal optimist, so I will find a silver lining in anything. But you know, I pride myself in my public health training and my background, but I definitely think if you had asked me 2 years ago, we would still be doing this at this level, I would have said, definitely not. We would have had this under control. We have a plan. We would all be vaccinated, and I would have been so wrong. So I'm glad I'm not a betting woman, but I think that this has been a unique time to live through. I think that there's definitely lessons that we learned at the beginning that we can definitely still apply. You know, I think the takeaway that I still tell folks in the hospital, that I tell patients, that I tell people in Walmart is we're still learning. And I think if we can encourage people, and I think the hardest part is that everybody's tired. People are physically fatigued, emotionally fatigued. And so it's hard to be excited about learning something new about this. And being patient as the data changes, or as we're told to do something different than we've been doing all along. But I think to have patience and grace, and then to know that we're all still learning, and that as much as we have a lot of people who are experts in the field on COVID-19, or have really been leading efforts or doing things in this space for the last 2 years, the virus doesn't really respect that. And so there's space for all of us to learn something every day. And so I'm excited to have these conversations and share some things and learn some things. And I think this conversation will be really great.
Excellent. Thank you both for helping to level set. And I think, I guess, because I find myself talking to folks who are still unvaccinated, folks who are still not boosted, people who are still somewhere down a rabbit hole of the dark internet and all of its expertise there. Take that as you will. One of the things that is exceedingly difficult to try to explain is both the context as to how Omicron, the variant, seems to be a lot more infectious, a lot more contagious, but then at the same time, it seems to be more mild in how it presents symptomatically. So Dr. Jefferson Shaw, we'll start with you. I think if you could just share a little bit about what the science is saying in terms of why the variant seems to be more contagious, and also generally a little bit more information for attendees to understand, for example, why is it, for example, that the symptoms are more mild, but then kind of also layered on top of that, and this is for both of you, especially with your work with the pediatric population, what does that mean for our children who are at various stages of either being able to be vaccinated or be boosted? So we'll start with you, Dr. Jefferson Shaw.
Yeah, absolutely. So the first is reminding everyone that Omicron has, the variant Omicron has about 50 more mutations in it than were found in previous variants of this virus. So The SARS-CoV-2 virus, we always say it looks like a crown. It has these little spikes on the outside, the spike protein. And on that spike protein is where most of the mutations that have caused Omicron are found. The spike protein is what's responsible for your body kind of recognizing the virus, being able to attach to different parts of your nose and your throat and your lungs and things like that. So once you see more of these mutations going along, you can evade the immune system in a much more efficient way, meaning your body might not be able to recognize it as it was able to recognize the earlier variants. And also the other thing to remember is that with Omicron, we're finding that although, it's much more contagious and infectious, the transmissibility seems to be higher. The milder kind of cases of disease are more prevalent than severe cases. We think that part of that may be due to the fact that Omicron really likes the nose and the throat, but it has a harder time getting to the lungs, meaning it has an affinity to infect your nose and throat, which may also lead to the way that we are transmitting it to people, meaning coughing, sneezing, talking, any of those things, singing, whatever it may be. But all those droplets really are concentrated a whole lot, we think, in the nose and throat versus the lungs. The reason why so many people get hospitalized with COVID in general is because of lung disease, meaning they get infections in the lungs that cause pneumonia, cause inflammation, they can't breathe, they have lower oxygen saturation, lots of inflammatory processes, and then you end up in the hospital. That can kind of go into other parts of the body as well. But the biggest reason we're thinking that Omicron, that kind of big part in the nose and throat is a big reason why it might be so mild. The other thing I'll mention too is kind of transmissibility. So there are kind of two levels to it. One is, do we think that Omicron is more contagious because the vaccines aren't working as well against them? And if you're boosted, maybe it works a little bit better. That's one reason. And then the other really, again, as I mentioned, is how much of the virus is being spit out when you talk and when you're around people. It's a big reason why things like masks are helpful, because if you can really block those respiratory droplets that are coming out and coming in contact with others, then hopefully you can block the contagiousness of the virus as well. And that's sort of secondary to vaccines and boosters and everything else that we've learned so much about over the past 2 years. I think with Omicron, people, we've already said are very tired, and the information keeps being kind of different from what we learned back in early 2020 and then later in early 2021, and now we're in early 2022. Everything keeps changing and we keep learning about it. But I would say kind of good news is we just learned about Omicron in November, right? November 2021. It's not that long ago, and we've learned so much about it already via efforts here in the US, abroad, the really spectacular scientists in South Africa who first identified it. And I think that that's a good sign that, this late in the pandemic, we've come up with these systems where we can really find these variants quickly and better understand how they're working at a much more rapid pace than we could earlier. And so just to put a silver lining, because I'm not always a silver lining type of person, but to put a silver lining on it, that is good news. And so I think, as time goes on, we're going to continue to learn even more at a faster pace, which is going to be helpful to everybody, especially from a public health standpoint.
Excellent, excellent. And Dr. Robinson, we will kind of stay a little bit on this theme. I'm thinking a bit about the importance of the intersection with COVID, public health preparedness interventions, and education, thinking about all of the conversations that continue to percolate around should children be masked, should teachers be vaccinated, et cetera, and so forth. And then also thinking about the District of Columbia. Recently, they went back to school and they had a requirement where there had to be a negative COVID test before the children were allowed to go back to school, and the teachers as well. So just thinking a bit about, the tests that are available to kind of figure out whether folks are in fact COVID positive, and thinking about whether the at-home tests are as good as the tests that can be administered by a clinician, but also thinking about other methods to protect our teachers. We often, of course, hear about, the children and the students, and think about the fact that just the recommendations aren't necessarily where they need to be for 100% of students, school-age students, to get vaccinated and boosted, but they are for teachers. And so just thinking a bit about the intersection with the testing, the rapid testing, the volume of rapid tests and testing that's needed to help facilitate the return to in-person education, but also protecting teachers in the midst of concerns about still, the Delta variant being out there. Omicron is taking up a lot of the news cycle, but, there's still very much so Delta out there. And I'm not sure if the test discerned one variant from the other. So whether it would be helpful even to provide more information about the type of variant that's infecting individuals.
Sure. So that's, I think it's a big question. I think there's a couple of things. So I'll try to go in reverse order. You may have to remind me. So I think as it relates, I think this is a big question that we get. I just had this big conversation with my mom yesterday about why doesn't your lab at the hospital just test and tell people if they've got Delta or Omicron? And the issue is that in order to determine if it's Delta or Omicron, you've got to sequence the virus. And sequencing of a virus is very expensive and more time consuming than you want for whether it's your swab your nose test that folks are doing at home or even at a hospital. And even the most major hospital that's got all the resources and, folks here, I'm in East Texas, people are like, oh, it's because you're a small hospital, or people are like, oh, we're a big hospital, we're too busy. It's just that doing the whole sequencing of a virus takes so long and it's an intensive process that in order to do that on a large amount of people in the time frame that we're looking for, because what you want is a test that's both rapid and good. And the challenge is you've got a lot of things that are rapid but may not be good. And you've got a lot of stuff that's really good, but it could be like weeks before the information gets back to the person who was infected with the variant. And so that's why right now at our hospitals or your clinics or your over-the-counter tests, you can't determine if it's Delta or Omicron. I think that in the past, it hasn't really mattered what variant you had because you're just going to be coughing and sneezing, and eventually you will get better or go to the hospital, or you'll get very, very sick and have a very negative outcome. I think the thing that's changed with Omicron that has us a little more concerned and may change things, and why folks are wanting and why it is important to know if you have Omicron or Delta is because your therapeutics are different. And so one of the things that we're grappling with here in Texarkana is we have a large amount of people who have been tested for COVID-19, have a positive test, and are waiting to get a monoclonal antibody therapy to treat them so they can feel better. And they're getting that at our county infusion site. And we had the Regeneron that the former president got and miraculously recovered. And we have another monoclonal antibody that's called bamlanivimab etesivimab. Nope, said that one wrong. We call it BAM-ED, but we have patients who've been getting that one. But now those two treatments are not effective against Omicron. And so that sounds great when we're in our meetings. It's easy for me to say out of my mouth, like, hey, these medications I have right in front of you don't work for what you have. However, if you are somebody who has COVID-19, or if you're on a wait list of 500 waiting to get treated, you're like, you have it there. I want what you have. You need to give me what you have. I think in some areas of the country, you've got people who are like, I understand what the science says. I'm just going to go home and wait until you get the medication that works. And in other areas of the country, people will say, this is an open carry state. Here's my gun. Give me this medication that you have right in front of me. And so it creates a very challenging treatment dichotomy across the country, but really as it relates to these viruses and how do we treat them appropriately and how do we help people understand why we would be withholding a medication. I think that the next challenge is that for Omicron, the monoclonal antibody therapy that helped so many people stay out of the hospital the last time this all happened is in limited supply. So that's a sotrovimab, and that's a monoclonal antibody therapy that you can use to treat COVID-19 in the early phases that will help people recover faster, but it's in limited supply. And so when you have a lot of people who are sick and only a little bit of medicine, I think that also creates a little bit of strife in your communities, and it leads to this kind of confusing picture where you say, okay, COVID-19 is more mild if you get Omicron, but if you're vaccinated, it may not be as mild as if you had been vaccinated. But here in this part of the country or this part of the state, we have a lot of people who are not at all interested in getting vaccinated, but are very interested in signing up to get monoclonal antibody treatments. And that's, I think, a fascinating thing because even for someone like me who has a medical degree, if you sat me down and talked to the science of how you make a vaccine and the science of how you make a monoclonal antibody, neither of those things I could do in the safety of my own home. And so if my argument was, I don't know what's in that, seems like that would be the same for both of those things. But I digress. I think a lot of the confusion is also driven by this fatigue. So you've got people who are like, okay, COVID's bad, I'm getting my vaccine and then we're going to be good. Or I'm going to get COVID's out here, I'm going to wear my mask and get my vaccine and we're going to be good. And so many people did that and felt like they followed the rules and did those steps that they feel like they should be able to be kind of free now. And those are the folks who are like, I don't know that I want to get my booster. I don't know that I want to get my kids vaccinated. And that's starting to become a challenge as we talk about how do we return to your business or your school or your job safely. Because I think all we can say is, from what we know right now, the best thing to do to keep yourself safe and to prevent death or prevent a serious hospitalization is to mask, get your vaccine, and get your booster. And by I mean anybody who is eligible. And I think that's a lot of conversation to have. And there are very few people who have, not very few, but I think there's probably not enough people who have bought into that whole entire package to have those conversations with the people who haven't.
All exceedingly valid points. They're bringing out the pessimist and the cynic in me, but I'm going to try to remain an upbeat moderator for this conversation. And I'll just say, I think one of the challenges when you talk about all of these different perspectives, I'll call it, however informed they may be, is that, the kind of end user, the end result here is a child who relies on adults to make good choices and smart decisions so that they can both be healthy and, have their opportunity to go to school and develop, et cetera. And teachers also rely upon responsible parents sending children who've been in safe environments so that they can themselves remain safe for them and their families. But one of the, in addition to Omicron and the memes going around with him and this variant, I think one of the other interesting parts here is the trending topic of the CDC and its shifting guidance in this land of both Omicron and shifting kind of requirements once you've had a COVID exposure. And so kind of picking up on the phrase that Dr. Robinson used, you want something that's rapid and good. Dr. Jefferson Shaw, I think it seems that there's kind of an inherent tension between needing a test, a negative test the day before you're expected to go back to school, and then both having a rapid test that does not produce a lot of false negatives. Yes, that's the phrase. So generally, I guess in some sense, just from your perspective, not thinking about your organizations and the hospitals with which you're affiliated, what's your take on the shifting guidance from the CDC and how it is being received, but also in light of the Omicron variant and kind of the milder symptoms and all of the kind of cultural and social points that Dr. Robinson raised? What do you think about the CDC and its kind of moving target here for what is best in terms of an exposure?
Yeah. So one thing, the memes are hilarious and so creative, but I'll say the CDC, it's one of those things where as we learn more information, we should give room to change guidance, right? And so that guidance has changed multiple times over the past 2 years from CDC and from the FDA and from every other kind of public health system in the country. But I will say that we also should have better explanations about why guidance is changing. And I think that the messaging there has not always been the best, generally speaking, about why we're changing different things. So, initially we were saying we need to isolate or quarantine for 14 days, and it was 10 days. And that caused a big hoopla at that time. And then now we're saying 5 days for people who are asymptomatic or have very mild symptoms. One thing to note is CDC clarified their guidance saying that if you have more moderate symptoms or severe symptoms, the guidance is still 10 days of quarantine. It's not 5 days. And then there's this whole thing about after 5 days, then you need to wear a mask and da-da-da. Anyway, it's not clear. And I think that's the biggest thing. So I think the public usually, if things are not clear, it starts to make people feel antsy and think that maybe you don't know what you're talking about, or maybe you are not telling us the right thing, you're keeping something from us. And I think that's something we've been battling this whole pandemic about, kind of how we're doing messaging so that people can trust what we're saying, what the messenger is saying. And so I think there's a lot of room for improvement with that piece. Now, reasons why the CDC changed it to 5 days for asymptomatic and mild, if you really look into it, it's because we think that most people are most infectious early on in the course of the disease, meaning if you got exposed and infected on day 1, we think that probably actually before your symptoms even started, you were most contagious like 2 to 3 days before that. So, a 5-day quarantine period for people who have asymptomatic or mild disease does actually make sense, but you have to put the message out there as to why it makes sense and get people to understand that. For more moderate to severe disease, the reason why they kept it at 10 days is because we think that people who have more moderate to severe disease probably can shed a little bit longer, maybe infectious a little bit longer. And so you want to keep that into account. The last thing I'll say, and I know a lot of people feel, and I feel very antsy about this too, and I have a background in bioethics, we call it kind of like an ick feeling that you sometimes get with certain decisions that are made. That ick feeling about, okay, what is the percentage of people who are actually contagious after 5 days, even if you have mild or asymptomatic disease? And we know that there's a risk there, right? That we can't say 100% of all people are going to absolutely positively, without any question, have any sort of transmissibility after that time. But we have to balance that against kind of everything else that's going on. Do we need people to get back in school? Do we need kids to be able to go to learn? Do we need to do these things? And what are the other ways that we can mitigate that risk? So wearing masks at work, making sure they're not cloth, making sure that they are good quality, things like that, making sure we're still doing all that other stuff, hand washing, distancing, not going to crowded places, all those other things that mitigate risk. And then also on top of that, vaccines and boosters. And so I think, if we put all that into perspective as it's just not one thing or two things, that it's many kind of factors that we need to put into play. And, at certain points in the pandemic, they had these kind of, what were they called? Swiss cheese models, where you have a layer of protection plus another layer plus another layer. And every layer may have a little bit of holes in it, but if you layer them all together, the effect is going to end up being very good versus just one measure alone. I think bringing all that into perspective is always good, and explaining in very clear terms why we're doing things, why we think that most people are infectious early on, why we think 5 days for this particular cohort of folks might be appropriate versus other people, then I think you can swallow that pill a little bit easier. But in general, and this has been top down, bottom up, whatever, for the whole pandemic, messaging, talking to people, being transparent, making sure that we're saying things that make sense in a timely manner, but then also at the same time, reminding the public that things change and that we have to try to figure out the best ways to inform people of those changes that make them understand and trust what we're saying. So I'll stop there, but.
And I'd add to your point, Dr. Jefferson Shaw, I think one of the things also is that I think communication is so key. And I think one of the things I realized in public health, and you and I are both physicians, and so we're taught in med school to kind of communicate with patients, but nobody in med school is like, this is how you do an interview, or this is how you do a podcast, or this is if a media comes and gives you this soundbite or gives you this question, this is how you respond. And so in my previous role at the Department of Health in Pennsylvania, I was just like, okay, I'm a doctor. I care about health. You want to ask me questions about health? Sure, I got it. And, I think that works sometimes, but then you could ask difficult questions. And I can tell you for sure, Dr. Fauci is a great scientist. His role, he was hired to be a scientist. He is trained as a scientist. He does scientisting well, but being the face of the CDC and communicating that may not be his strong point. And I think that's the challenge. And so I think what the government needs to decide is, do you have someone who's just your communications person who knows how to make it sound like it makes sense? And that's the person who says all the information, or do you need the person who is the doctory person to make that information make sense? I think the challenge is you've got a lot of doctory people on social media who are like, oh, here's my white coat, and now let me tell you how I feel, versus what the science says. And I think that has been a challenge of misinformation, that there's no kind of kind of systematic way for us to combat that. I think it's kind of a one-on-one. And then I think the CDC comes back and says, don't believe misinformation. But then it's hard to know for some folks who believe the misinformation, which is the misinformation. And so I think that part is confusing. And I think another piece is that, public health has been for a long time also an academic, even though it's not usually like an academic organization, right? CDC is a governmental organization, but it's a study, right? So you get your information, you study it, you want to make sure that you really understand it so you can make some deductions from what you've been studying. So I study it over some time, I think about it, I look at other data, I research. It's a long process. And at the end of it, you've got some really good data because you've taken a really long time to study it in a very methodical way to get to a conclusion. When you rush it, so, anything that we've done over the last 2.5 years, it makes it very difficult to get to the right answer the first time in a short amount of time. And I think that's challenging. And so I think because we have continued to give this information out piecemeal and kind of fast, we kind of get behind ourselves as we're trying to put it forward. And I think the other piece is, it's very easy to say, okay, after 5 days, you should be fine. But you don't know how this person coughs. You don't know what they do on their weekends. You don't know if they then kind of hung around without a mask with other people and then got reinfected. And so I think it's difficult to generalize. And I think in healthcare, we like to use, odd numbers. So 5, 7, 14, 10. I joke, I really liked infectious disease when I was in med school. And I was like, but how do bacteria and viruses know that after 7, 10, or 14 days, it's time for them to go? Like, how do they know that is their number? And then I had an attending physician who told me, he's like, they don't. We just basically picked numbers back in the day when we needed to put them in there, because there's no way that viruses, bacteria, and molds, fungi, all those things in 7, 10, or 14 days are automatically gone in 100% of people. And I think that's something else that I think people need to understand. But as we increase transparency in healthcare and start sharing all these truths that we knew within ourselves as healthcare providers, when the general public gets that, I think it also kind of starts to eat away at the trust that people have in the healthcare field, because it's like, well, have you been telling me the truth? And that's what opens us up to challenges in vaccinating children, right? So we're not even talking about COVID vaccine, but if you look at vaccine in children across the pandemic, routine childhood immunizations are being missed. And more people are choosing not to vaccinate their children with vaccines that have prevented communicable diseases for almost 100 years. And part of that is because the last 2.5 years has showed people, maybe we don't need to have blind trust in the healthcare field. And so it's opened up a space for a lot more questions. And I think a lot more questions with providers is a good thing, but I think our providers also need to be in a space where they can hear from parents and hear from patients what those concerns are and say, okay, I definitely know this piece I don't, but I'm going to go back and look at and get that information for you so we can continue to have this dialogue and make sure that we make a decision that's right for you and right for your family.
I mean, you both have said a treatise, and I co-sign and echo the importance of all that you say. I think I often joke with my friend circle that what we're dealing with now are the failures of our public education system. To let people come out of school with essential understanding of viruses and infection versus everyone going through freshman or sophomore year biology dissecting a frog. And those sorts of things are, I think, challenges, as you noted, when public health stops being this quirky little thing and starts being something that actually is present and visible in everyone's lives on a daily basis. And I think one of those very examples is also kind of echoed in the comment about the poll question about whether, you or someone that has been exposed to COVID or the Omicron variant, recognizing that, we don't know, for example, as Dr. Robinson alluded to, what variant necessarily you may be infected with if you do present with a positive COVID test. But it says here that, by and large, 95% of the folks who are with us today know someone who has either had it themselves, multiple people that have had it, et cetera. And just recognizing again how ridiculously the COVID infection rate has been worse. The COVID symptoms and the outcomes have been exacerbated, particularly among communities of color, particularly among folks who have certain certain conditions, certain diseases. Those things are very evident and prevalent in our community. And I think when you, Dr. Jefferson Shaw started this commentary, but the importance of trusted messengers, the importance of being able to speak to a lay audience about very complex things is exceedingly relevant in a time such as now. And without having any sort of financial incentive for doing so, I just want to encourage folks to look up Dr. Lisa Fitzpatrick and her organization, Grapevine Health. She's an infectious disease epidemiologist who used to also be the medical director for DC Medicaid, but her organization is basically looking at that very issue, looking at the fact that the literacy of the general public, the trust of the general public with physicians and clinicians could use some work, it could use some refinement. And that organization is doing a lot from the vantage point of underserved communities and marginalized populations to try to start tackling that very issue. And also just echoing what the panelists have noted, you know, it's important, I think, to have varied messengers. I think one of the things that happened during COVID, particularly with a lot of the funding that Congress approved at the beginning of the pandemic, was it was available to different messengers. There were community-based organizations that were able to do some things and go out, and they did a lot of work with faith-based communities to deal with, you know, inequities in health in terms of the trust of the kind of medical complex. But is that still happening? You know, have those resources all been used up? We're now again in the third year of the pandemic. Where are we in terms of making sure that we continue to find messengers who can speak to folks? I remember, you know, at the beginning, there were even a lot of, you know, rappers and influencers that folks were trying to use to talk about getting vaccinated. But then, you know, now with Omicron, we're left again with Dr. Fauci, and you know, God bless him and all the work that he's done, but he's a man of a different generation. And oftentimes those things just kind of, you know, fall on deaf ears just by virtue of time and generational gaps. And so I do think that it is very important to continue to think about, you know, not just who the messengers are, but just the fact that general public comes at all of this information from different places of understanding. And if the physicians and clinicians on the ground can have the same sort of approach to understanding these issues as our panelists today, I think we can make some inroads there and improve the way folks understand these very complicated topics. But looking at the time, I want to make sure that we cover some of the questions that have come from the folks who are attending today. And some of them we've kind of touched upon, but I do think there are a couple different angles that we can highlight and allow our doctors to opine on. So Dr. Robinson, going back to some of the conversation that you had started with in terms of treatment, and this is actually for both panelists, but you mentioned, for example, patients come and they say, I want this. But from the vantage point of the learned clinician, what are the differences, for example, in terms of someone who might be prescribed a monoclonal antibody? And this is also still recognizing that we were educated on the fact that these current you know, interventions are somewhat ineffective against Omicron, but then also looking towards some of the therapeutic pills that are that have been announced, some of the things that are on the horizon in terms of treating COVID. Just curious, you know, are there kind of specific presentations of patients that automatically would qualify for a pill versus something that's more along the monoclonal antibody? And also just, I think, going back to that question of educating the patient about their variant. Is this something that the science could, you know, ramp up in terms of its ability to do so? And do you think that it would have any benefit to the general public if they were given that information in a more timely manner?
So I think there's a couple of things. I will tell you that there's plenty, I would say most, doctors who cannot keep the treatment straight. There have been so many and they've come out so fast, and they have just as much trouble pronouncing them as the general public. So I think there's that piece. But I think it would be helpful. And I mean, I think there should be, you know, an article on CNN, like these are the treatments that are currently available and who may qualify, just to help people start to wrap their mind about like what's going on and am I somebody who needs treatment? I can tell you for sure people who are, we said immunocompromised, then we realized that actually is a lot of people. So someone who has COPD, who takes steroids frequently during the year because they have trouble breathing, or who's on a regular steroid inhaler, has a certain degree of immunocompromise. And I'll let Dr. Jefferson Shaw kind of speak to that a little bit more. But that's a different level of compromise than someone who has a cancer that's active, who's currently getting chemotherapy. And that's different from a pregnant person. So someone who is pregnant is also considered high risk. So I can tell you at our hospital, it's difficult just because of a staffing and a space perspective to do monoclonal antibody treatments for every single person who has COVID. And it's something that's supposed to be done as an outpatient, meaning you go to a center or you go to an urgent care, you get the infusion or you get a shot and you go home. And the hospital is not really doing that in our community. But we do have a lot of pregnant women coming into the hospital who are there for other reasons. We do a swab, we find out that they have COVID, and we're offering them the monoclonal antibody treatments because pregnancy is a high risk category, meaning that the person is at risk for a high risk outcome, but it also can affect the fetus or the baby. And so we want to make sure that we can help these people who are pregnant go to term and have as healthy and as full term a pregnancy as possible. And so those monoclonal antibody infusions are for, we'd like to say for sure, prioritizing our people who are immunocompromised or having an underlying condition that would make it very difficult for them to recover from COVID. In general, if you're young and healthy and you isolate and do all the things that your grandmother or all the things that the memes say, so drink your ginger ale, drink some chicken soup, get all the elderberry and all the A to Z vitamins. By the end of the week, you're probably going to get better on your own, but you'll feel a lot better. And your mama will feel a lot better when you tell her that you got better after you did the thing she said. But if you're someone who has underlying conditions, you may need some extra help. And that's what those monoclonal antibody infusions are for. That said, we know that doing an infusion means you got to get in a car, you got to get somewhere, we got to have a nurse there, you have to have a doctor at the order. There's a lot of steps involved. It's a little bit complicated, which is why we really push to get an oral pill or a treatment so that we don't have to go through all those steps. Again, I think that the general public obviously could take these oral treatments and get better if they got COVID. But what we're trying to do is prioritize these high risk groups. So someone who's already got something that they're dealing with or managing as a chronic illness. So not necessarily a diagnosis of HIV, but if you have an advanced HIV diagnosis and you get infected with COVID, you're somebody who would be considered more high risk. And we want to make sure that you have a positive outcome. And that would be somebody for whom either a monoclonal infusion or the pills that are now becoming available would be an option. There are 2 pills that are available. It's the Paxlovid and the Molnupiravir, still practicing saying them. But they're both in very limited supply and very limited quantities in terms of how much is available and where in the country it's being shipped to. So the federal government is doing a distribution based on the number of cases in different areas, and that's how those drugs are getting distributed. And so I think the challenge is when we give this information out to the general public and say, hey, here's the treatments that are available, or here's what's been approved, and someone's like, okay, well, I want Paxlovid. I'm going to go get me some Paxlovid today. And then you find out that for a county of 200,000 people, there are 20 doses. That starts to create some anxiety for some, panic for others. And that's what we're, I think, trying to avoid. And so I think that's why people are maybe not being as, I wouldn't say forthcoming, but I think the reason that we're not pushing more to share information about these medications is because there's not a lot of them available. And we're trying to make sure that the people who need them the most, who are the sickest or at risk of becoming sick, are prioritized by providers for getting those. That said, I think as we've seen in the past, certain communities prioritize patients who look a certain way or who have a certain income. And so I think making sure that people understand that this is about underlying condition and not just because someone's a CEO at the big company in your city or your town, that doesn't get them the treatment. What gets them the treatment is them having an underlying condition. And actually for our hospital, you have to certify that you have to check off one of the conditions that the people have to try to get them that medication.
I think that's very helpful. And I think, go ahead, Dr. Jefferson Shaw.
No, I'm sorry, I didn't mean to interrupt. I was just going to mention one other kind of treatment consideration. So right now, at present, the way that the monoclonals are approved are for non-hospitalized patients who have kind of mild to moderate disease, who are at risk, as Dr. Robinson mentioned, for more severe disease, hospitalization, or death, based on a variety of different underlying health conditions and immunocompromised conditions and states. The one thing too, though, is that they recently came out with this kind of what we call pre-exposure prophylaxis. So the ultimate pre-exposure prophylaxis is vaccines, obviously, but there are other ones that are available now, and it's called Evusheld for people who are immunocompromised specifically, and who either have a poor response to vaccines, meaning they might be on a certain type of medication that really blunts their immune response after they were vaccinated, or people who are unvaccinated, but who are at high risk for these bad outcomes. So, you know, as an immunologist, we have a lot of people with underlying just primary immunodeficiencies, people who have cancer, things like that, who you know, maybe they did get the vaccines, but they just didn't respond in an appropriate way. And they've gotten their 3 doses, including their booster and all that. Or people who, you know, for whatever reason, chose to not get vaccinated or could not get vaccinated. And so that's another consideration as far as kind of newer treatments, prophylaxis, things like that, that we have on board today.
And I just wanted to add, so there's a resource that was shared by Dr. Kristen Herring in the chat that gives an overview of the current treatments. I think this is a really good overview. It tells you what's currently available, what it's for, how it's used, and who would qualify. And I appreciate Dr. Herring adding that. She's been a big resource for me during this pandemic as I've tried to talk some sense into some folks locally. So thank you for being on the call, Dr. Herring.
And I think kind of, you know, following up, we're all the way down this kind of spectrum of what happens when you get it. But Dr. Jefferson Shaw, I mean, I'm trying to still be a little bit of an optimist and recognize that there are still things that folks can do to try to reduce the likelihood that they will get and contract COVID-19 and its various variants. So I think, you know, just also thinking about, we're still in this very politicized time where the basics seem to be problematic. And also there seems to be less of a push for the basics like hand washing, et cetera. Can you just, I guess, give us a little bit of a reminder, or, you know, give us some of your learned expertise in terms of remembering that there are still things that we can do before we even get to the need for some type of pharmaceutical therapeutic or treatment?
Absolutely. So first things first, wear a mask. That's really the top thing, especially with Omicron. We know that with every variant of COVID-19, the respiratory droplets have been an issue, aerosolization of droplets have been an issue. And one way that you can prevent kind of spreading your own infection to others is wearing a mask. And then on the flip side, a way to prevent you from catching it from other people is to wear a mask. And, you know, really, if 2 parties are wearing masks together, that's really the ultimate, the best situation that you can be in. So that's number one. Masks are really easy to find now. There was a time way back early 2020. I know all of you remember when it was super hard to find good masks, and people were making masks out of all kinds of stuff at home. Like I myself sewed a mask together at some point, I'm positive, you know, but there are ways to easily get these things now from anywhere from Walmart to Amazon to whatever. You can find a good surgical mask. The other options, you know, as far as different mask types, we have surgical masks that are typically 3 layers. We have KN95 masks, we have N95 masks. All of those are good. We think for Omicron, probably if you're in a high risk situation, so most healthcare providers, probably a KN95 or N95 is going to be appropriate for kind of general everyday things. If you have access to those, then by all means use them. If you don't, a good surgical mask or even double masking, so you would have good 6 layers together, is appropriate. So that's the first thing. The second really is the general basics that, you know, mom and grandma taught you all. Wash your hands often, wipe down surfaces, keep everything as clean as possible. And, you know, very simple type stuff. And then the last thing really is trying to stay away. So that distancing, that social distancing that we've talked about this entire time. So putting space between you and other people who you don't live with. And you can do that at home, at work, at school, as much as you humanly possibly can. And again, with kind of layering these different things on. So a mask plus social distancing plus hand washing, and then ultimately vaccines, boosters, and everything else are going to really protect you. We know that the vaccines lose efficacy with Omicron. We know that boosters help to bring that efficacy back up. And so for people who are already vaccinated and you haven't gotten your booster will help you. But for people who are unvaccinated, getting that primary series initially is going to help you. And then when the time comes, getting your booster as you can. So those are the big things. And then I failed to mention earlier sort of about kids. And you mentioned this before, kids are so susceptible to all these things because so many of them have not been vaccinated or cannot get vaccinated yet. And really they're counting on us, responsible adults, hopefully responsible adults, to make good decisions to keep them protected. So, you know, that goes with vaccines and boosters and everything, but that also goes with putting kids in masks when they go to school, making sure teachers are doing the same, trying to distance as much as possible, figuring out if it's a place where you can be outdoors, being outdoors more than indoors, all of these different measures to really decrease the risk of transmission and infection in these populations.
I think you opened up a new fun thing, Orriel. Ariel, is that even right now, the Supreme Court is hearing arguments about this vaccine mandate. So I'm over here hitting refresh, because they keep putting meetings on my schedule and then deleting the meetings. But thinking about vaccine mandates. And so, me with my pseudo employer hat, trying to make sure that my medical staff is all vaccinated, of which they're not. We have an intensive, one of our ICU doctors who has taken care of patients this 2.5 years and firmly refuses to get vaccinated, and sent me both a written religious exemption as well as a medical exemption. So he's got both reasons as to why he doesn't need to get the vaccine. Neither of them, none. His medical reason is not any of the actual medical reasons as outlined by people who study vaccines. But anyways, I digress. But one of the things that I was just thinking about when Dr. Jefferson Shaw was talking was, so my 2-year-old is in preschool, and I was told on Wednesday that the teacher who took care of him on Monday and Tuesday tested positive. And nobody wears a mask at his school at all. And I mean, I think they try to wash hands, but they're 2. And so every day I pick them up, I'm like, oh, this is exciting. I think about what a vaccine mandate would do to obviously protect the staff at that school, but then thinking selfishly about my child, I was like, oh, I hadn't thought about, obviously I think about how vaccines protect our hospital employees and then our patients. But then if you think about kids in school, particularly those who are too young to get vaccinated, I think masking and vaxing is the best way that we can protect those who can't get vaccinated yet.
Well, I certainly needed to touch on the issue of mandates. And I think even considering that we're at the Supreme Court with mandates about base vaccines, and we're already seeing other countries encourage their citizens to get 4th and 5th booster shots. And so the lawyer in me actually was going to leave that landmine alone and just leave it for the learned Supreme Court to figure out what is best, having done a bit of research about 10 years ago on healthcare worker mandates just around the flu vaccine. It's certainly something that has only ramped up in its intensity. And I think it's certainly something that also speaks to the importance of your specialty training. Thinking about that clinician you were just speaking of, there's a reason why there are years and years of training that go into being an infectious disease specialist versus being an internist and other types of, clinicians. So we just hope for the best. We hope that, the Supreme Court does what's in the best interest of the public health. And we also hope that government kind of guidance continues to think about the kind of vulnerabilities that set certain populations up to be more susceptible to COVID in the first place. And one of those populations particularly is folks who suffer with obesity, recognizing that there is more and more literature that characterizes obesity as a disease, that characterizes obesity as something that COVID has a particular affinity for in terms of the cellular structure of fat cells. And I think also, on my day job, this being the last day on that job, but on my day job, there's a lot of advocacy to get more recognition of obesity treatments within public health, federal healthcare programs, one of which particularly being Medicare. But, I think the interesting thing is in the Medicare program, you have it caring for people with disabilities, people who are older, and they're already more susceptible to COVID. But I think when you consider, some of the lifestyle conditions that have made folks more susceptible to COVID, it would just be, I think, interesting to think about, and Dr. Robinson can respond to this, what are some of the things that you would give, what was some of the advice, I guess, you would give folks who may be suffering with obesity to help them keep themselves safe from COVID, and kind of what recommendation would you make to, policymakers and folks who are looking at opportunities to do more in this space to try to avert further complications there?
I think it takes a multi-pronged approach. I think we need to stop I think there's this very blame the patient mindset. And I think it goes beyond, it's actually in the exam room. So you've got doctors who are judgmental, and then it goes all the way up through, across our society, whether it's what we see in social media, what we see in media, what we see in products that are trying to be sold to people, what we see in terms of the size of airline seats. I am not obese, but I can tell you that airline seats are barely big enough to kind of let me get in there. So I can't imagine what it's like for someone who is obese or who suffers with obesity and is trying to figure out, how do you fly comfortably? How do you get in a car comfortably? So, I think obviously it is a health condition. It's something that we need to work with people on, but we also need to make sure that there's appropriate accommodations within our society so that people can live a happy and fulfilling life without feeling like they're being judged at every turn. I think as it relates to COVID-19, I think the most important thing is to wear your mask, get your vaccine, and get boosted. I think thinking about obesity as a chronic health condition and making sure that folks know, like, hey, that is as relevant as diabetes, and you are someone who's at high risk for a bad outcome. So make sure you get your booster. I think making sure that we have more spokesmen and spokeswomen who have obesity as a medical or a health condition and who are living their best lives and trying to be healthy and doing those things and owning it, and having them speak about COVID-19 armed with the facts, I think would be helpful. And then I think the other piece is, we didn't speak to this a ton, but I think social distancing is important. And so I think as we have this race to the bottom or race to the top to get back to like life as normal, or decide, hey, we're going to be COVID safe, even though we can't be COVID free, that does mean, like, yes, you probably can get vaccinated and gather. You probably still need to wear masks. But I don't know that when you have a surge, it's the right time to be having large meetings and conferences of thousands of people. It's very hard to socially distance when you're around thousands of people. It's very hard for thousands of people within that, for someone not to have a mask on, for someone not to have had a recent exposure, for someone not to touch something without a mask or not washing their hands. And you get at really high risk for a super spreader event. And so I think we've got to figure out not only how do we take care of ourselves within our homes and at work and in our day-to-day lives, but as we work to get back to life as normal, and we have these larger events, how do we keep those COVID safe? And what is our criteria for saying we're in the middle of a surge, we're going to delay this event? What is that? What does that look like? And that's a lot of the conversation I have now. When do you bring large group of college students together? When do you say you can be back on campus versus doing virtual learning? And I think trying to think about that piece is going to be important.
Well, we've certainly talked a lot and we've learned a lot, and we could probably stay on here for another 15 to 30 minutes, making sure that we covered all the various nuances of issues that have popped up in the chat and in the Q&A. So apologies for not being able to get to all of those this afternoon, but in the interest of time, I'm just going to take the moderator's privilege and thank our panelists immensely, not just for joining us today, but for the enormous burden of caring for us throughout the past 2 years plus, going into the third year, and the sacrifices that all clinicians are making to try to keep us as safe and healthy as we can be. I joke with my colleagues often, on behalf of an ungrateful nation, we're very appreciative of all you do. And we hope that you continue to keep yourself safe. And thanks so much for sharing and imparting your knowledge today. With that, I'll turn it back over to Brandon.
Oh, yeah. Well, thanks so much for moderating, Orriel, and congrats on the new job. I get from this moderating to tell why you were recruited away. And as always, my two, Evan didn't mention this, I was going to give them my happy Founders Day to the two of them coming up, the two AKAs that have done a great job today on the panel and educated us. I think while during the conversation, I texted or sent the link to many friends because they had all these questions that they're asking me. And I was like, oh, just watch this, because they're answering all the questions that you have. And so we really appreciate it, and we appreciate you like sort of leading off the year. And if the year goes like this presentation went, I am very excited. So without further ado, we'll see you guys soon. Thanks again, as always. And we're hoping to have a summit in April. We'll see how it goes. We'll talk to both Dr. Shaw and Dr. Jefferson Shaw and Dr. Robinson. So fingers crossed. Have a good day.